Hello, welcome everyone. So this is an educational video on lung ultrasound in COVID-19 pneumonitis. I have done a literature review, and there's not too many papers out there really to cite. There's a few case series and case reports, but not a great deal. So this one is fairly recent, from 2021. And they have come up with a few examples of what you can see in COVID-19 pneumonitis. So B-lines are always a big part of the findings that we see in COVID-19, and they reporting coalescent B-lines, so that's many B-lines coming all together and sort of bringing this shiny white looking lung. So these are many B-lines all coming together. Or you can have distinct B-lines and emanating from that slightly thickened pleural line over there. So these are the B-lines as shown on the image. They also mentioning a scoring system, so that you count these B-lines in each zone, R1, 2, 3, 4, L1, 2, 3, 4, and then you add them up, you come to a number, how many B-lines you see in that patient. And then they have produced some quite complicated decision tree and algorithm, but I really don't see the utility of that, because it's all about clinical assessment, and lung ultrasound really is just one little piece of the puzzle. So you use it as part of your physical exam, your investigations, and your lung ultrasound will be part of the whole big picture. So it gives you a bit of extra information, but on its own, I don't think it should drive management. Together with everything else, you just put it all together in your mind, and you pull up that mental image of that patient. For that, it's very useful, but on its own, I don't think it's enough to make decisions just on what you find in lung ultrasound. There was a recent review and an international expert consensus. So this is 2020, as you see. So they came up with this quite early in the pandemic, and they have assessed quite a few papers, and they try to come up with like signs and findings that you can see in lung ultrasound. And as we know, chest X-ray and lung ultrasound is always more sensitive than chest X-ray. It's as good as a CT chest. In good hands, experienced people can find tiny little abnormalities. Lung ultrasound can diagnose COVID-19 pneumonitis, even in asymptomatic patients with normal vital signs, although you would argue, why would you do a lung ultrasound in a normal patient with no signs and normal vital signs? So, but anyway, so you can find those findings in patients, and you can distinguish between viral and bacterial pneumonia with the lung ultrasound. So this is what you find. These are the most frequent findings. So you have B-lines either on their own, so like isolated B-lines, or you can have confluent B-lines, and these are the corresponding signs to ground glass opacities on the CT chest. They came up with this new term called light beam, which is sort of similar to a confluent B-line, but it comes from a normal pleura, and it comes and goes. So it comes into view and then disappears. So they call it light beam, and they think it's quite specific for that COVID-19 pneumonitis. You can have pleural line abnormalities. So instead of that smooth, nice, thin pleura, you have a thickened pleura with irregularities. And then due to pleuritic chest pain, you can have like reduced lung sliding due to that pain and reduced breathing efforts. Later on, when these patients get worse, they can develop larger consolidations with air bronchograms. All of these findings are bilateral, they're global, however they're very asymmetrical and they're very patchy in nature. So some parts of the lung appear normal, and then a centimeter from that you find these confluent B lines, and then again a centimeter from that you find a bit of a consolidation, and the next part again can be normal. So it's very patchy in nature. So these are from 2 different patients, and as you see, this one demonstrates those B lines where you have, on picture A, where you have quite a few B lines coming off, and then in the dorsal parts, those confluent B lines. And in patient B, again, in the ventral area, you find quite a few B lines. However, in the dorsal part, you see that they find some larger areas of consolidation, and then we'll get back to this on our case presentations as well. You can use lung ultrasound for checking on progress for these patients, and proning is an important intervention that helps with oxygenation, and you can check them before and after proning, and with that you'll see the difference in terms of atelectasis. So you can check how the aeration improves after proning, and lung ultrasound is a good modality for that. There was a landmark paper from Gattinoni when the pandemic started. They tried to characterize various patient groups, how they behave with their COVID-19 pneumonitis, and they put them into 2 large groups, the L group and the H group. And the L phenotype, as you see here, that is supposed to mean low elastance, which is high compliance or almost normal compliance. So these are the patients who have almost normal looking lungs. So on the images here you see there are some B lines but not too many, and this is the score I was mentioning. So they have some B lines but not a lot, and their lung weight is low, meaning that there's not much in terms of no edematous changes, not that severe, and low recruitability means that you don't have that much atelectasis and recruitment maneuvers don't work on them. So these patients would be the sort of the happy hypoxic patients. They look okay, they look almost normal, they're not short of breath, and their lungs are not that diseased. The other group is the H phenotype, which is the high elastance, which is the low compliance group, and these are the ones where you have many more B lines, as you see here. So the confluent B lines there, and some collapse and consolidation in the posterior areas, and this is where the compliance is low, with high shunt fraction, high lung weight, meaning that the edematous changes are more severe, and these are the ones that respond to recruitment maneuvers, including proning as well. So these are the ones that improve with recruitment. And they both have their own lung ultrasound findings, and you see how that lung ultrasound score here is 27, which is much higher, so many more B lines seen in all sorts of different lung fields. They have come up with recommendations how to use point-of-care ultrasound for other organ systems in COVID-19 patients, and you can use it, of course, for lungs, but at the same time you can use it for heart, to check for heart function, especially right heart function, with the increased resistance or strain on that right ventricle from lung changes, and also fluid status assessment, and to decide how much fluid to give to these patients. Another use for ultrasound is searching or looking for clots, because the earlier variants, so the Alpha and Delta COVID, they were more related to this whole body inflammatory slash thrombotic changes, including large thrombus and embolus DVTs, but also like in situ thrombus in the lungs and all other places, kidneys, everywhere. So you can use the ultrasound to look for these as well. And of course, when they intubated, you can use it to check progress, to check what your intervention did to those patients, like proning, and did it help or not. So lots of uses are recommended for these COVID patients. And then they came up with this nice poster, so you can put it on your ICU wall, and then it tells you what to do with these patients, so where you can use the ultrasound for these patients. So it's quite useful. A big part of the recommendations was infection control. And I think with the COVID and isolation requirements, the handheld devices became very useful. And these are small enough so that the whole thing can be put into a plastic bag, and then you can do your scanning, and then after that it's easier to clean and there's no cross-contamination. So it's very important to do good hygiene and good infection control. This one is from China, and quite early as well, 2019, 2020, and they describing their most frequent findings. They find that there's thickened and irregular pleural line, lots of B lines as a focally or confluent B lines. You can see consolidations with air bronchograms. It is reported, almost all papers agree on that pleural effusions are quite rare in these patients. If it's only a COVID pneumonitis, they very rarely have pleural effusions. And if there is a pleural effusion, then you should start looking for other causes for that. So like a heart failure component or a bacterial pneumonia with it. A lines will come back when they start to recover from the disease. And then as you see, so they describe that initially they have B lines, and then they get more coalescent, more confluent, and then later on you're gonna get consolidation in the sicker ICU patients. Each of these changes you will see on the CT, they all have their own corresponding changes in the lung ultrasound as well. So like one example, ground glass opacities, usually those come up as B lines on your lung ultrasound. Another one from China. So mostly posterior lungs are involved. B lines, lots of B lines, discontinuous or continuous fused B lines. Pleural line irregularities, small subpleural consolidations quite often, air bronchograms, and then tiny pleural effusions, but not a big basal pleural effusion, and you can get that pleural thickening as well. Posterior parts of the lung, or the more dependent parts of the lung, are usually more affected. And again, as you see, so you have B-line patterns and pleural thickening as one of the most important changes. So I give you a summary on radiology findings. So chest x-rays, they are less sensitive, and quite often they can be completely normal, even in symptomatic patients in COVID. So I've seen quite a few of those. Those who come in and those who have to be admitted to a hospital, almost 70% of them will have some abnormalities on their chest x-ray, and almost 80% of the patients who are inpatients, they will have some changes on their chest x-ray at some point. And 10 to 12 days is where they report the most changes on these x-rays. And we've seen that in our patient cohort as well. So quite often these patients are day 10, 11 after being diagnosed with COVID, and that's where they needed the ICU admission, that's where they need to come to us, because for some reason that's when it gets the worst. So the findings are airspace opacities. You can get consolidation patterns or ground glass opacities, bilateral but peripheral and lower zones, and very rare when you see pleural effusions. CT findings, ground glass opacities are the most frequent changes. So these are again bilateral but patchy, can be spared areas and abnormal areas right next to each other. You have this crazy paving appearance. So this is, I'll put the example up here. So this is really ground glass opacity with some septal thickening. So if you look at those CT reports from these patients, you'll see that they use this term quite often. So it's a radiology term that they use to describe these diseases. And then later on you have airspace consolidation and some thickening, bronchiectasis sometime later. And then the ultrasound findings, if you put all these literature review together, so B lines from focal to diffuse, you can have those light beam patterns as well. The pleura can be thickened with some discontinuities. You can have small subpleural consolidations, and very rarely you have local little pleural effusions. If you put the colored flow on, you'll see that these lesions are not very vascularized, and when they get worse, when they get into the more severe phase of their disease, then they can develop alveolar consolidation with air bronchograms. So I'll be showing these later in the case presentations. And when they get better, when these changes resolve with time, then the A-line pattern comes back, and that's the time usually when they leave ICU and they go back to the ward. Okay, so these are our cases from our local ICU. So this one was a 62-year-old male, and he had moderate COVID-19 pneumonitis. Didn't have much in terms of past medical history, just hypertension. He was otherwise fit. So he had 8 days of dry cough. He was treated with dexamethasone, ceftriaxone, and doxycycline. Initially, he was on low-flow nasal prongs, and then needed high-flow prongs with 45% oxygen, and had one very severe and a few other less severe desaturations on the ward down into the 70s. And that was when we took him to ICU sort of preemptively, where we did high-flow nasal prong oxygen therapy with self-proning. So self-proning was very useful. So we did that on almost every patient who was able to do it, and it worked magic. Their oxygenation improved significantly, and I think it really saved quite a few intubations for us. So self-proning is really a good thing to do. This is his first X-ray. Not very remarkable at all. So you can argue that there might be this right upper lobe haziness. So that's the only thing I think that you can see. And this is the time when he came to ICU. So you see that the changes are a bit more widespread. There's a bit more like alveolar consolidation, small and patchy areas of that, but not a big lobar pneumonia pattern. So this would be in keeping with that viral pneumonitis pattern. Lung ultrasound. So he was quite well actually when I saw him. He was on high flow, very brittle though. So whenever he was at rest, his sats were okay on the high flow, but when he did something, he always desaturated quite quickly and rapidly. So right upper zone of the lung ultrasound, this is a normal finding. You have the pleural sliding and the A pattern, which is normal. I did a few different areas, so this is still in R1, but as you see, just a few centimeters from the previous one, this one has a couple of B lines in it. So this is the patchy nature of those changes. So normal areas right next to abnormal areas. Still in R1, you can see that there is this, the pleura on this one looks slightly thickened there. So it's not as smooth, not as nice and thin as the previous one. So again, this is the patchy nature that these changes can be right next to each other. Again, thickened pleura, zoomed in on that same region. Pleural sliding is still there, and then the hint of that B line in the middle. So moving down to right 2, which is the lower part of the anterior chest. This is sort of normal, pleural sliding, A-line pattern. Still in right 2, but in another area, a couple of B lines over there. So, and then R3 up in the armpit. So this is more significant changes here. So see how these B lines are more confluent. So I'd say 5 or 6 B lines in this image. You see how those A lines get obliterated from the B lines. And if you think back to that light beam pattern, so I think one of these you could say that this is a light beam because it sort of kind of comes in and out of view, it disappears as the patient breathes. So it's sort of I think this is what they were describing as the light beam. R3 still, so see how, so this one looks even worse than the previous, so like a good 6-7 B lines or so. And then down on the diaphragm with R4, so you see the liver on the right hand side of the image, and then the lung coming in with almost confluent B lines in it. Same here. See how, oops, I go back. So lung coming in, and you see this one is the shiny white lung. So it's confluent B lines. Left side, upper part of the chest. This one's largely normal. L2, see how the pleura was a bit thickened there. So this is the pleural thickening and irregularities. And then if you go into L3, so this image is a bit different. It's looking sort of in between the rib space. So you rotated your cardiac probe so that there's no rib shadows this time. So you see how that pleura is much longer here. But you see how it's irregular. So there are these little undulations in it and then B lines coming off it. And then if you go down to L4, this one's not as bad, so the B lines here are not as pronounced. Same here. See the diaphragm and the spleen. So this base looked a bit better than the right hand side. So all in all, we have seen quite a few changes in this patient. However, clinically he was okay. Only spent a couple of days in ICU, and after that he went back to the ward and recovered. So this was good. The second case is a 71-year-old guy who had severe Covid19 pneumonitis. So he had a knee replacement a month ago, and then represented with shortness of breath. So in the differentials we had a PE in there as well with the recent knee surgery and immobility. So we echoed him as well. There were no echo signs of a pulmonary embolus, or at least not a large pulmonary embolus. But we did see quite significant changes with his lungs. So first he came into ED with some shortness of breath. They sent him home, and then 2 days later he came back with more severe shortness of breath. That time they gave him steroids. And then he was admitted to the ward, but then within about 12 hours from low flow nasal prongs, he went to high flow nasal prongs on 65% oxygen. So this is within 12 hours. So then we decided to bring him to ICU just because his trajectory was quite severe. And then he was intubated there. And he spent 4 days on the ventilator, and then extubated and recovered quite well. So he did well in the end, but this was more on the severe end of the spectrum. First chest X-ray on the first presentation, so roughly or really largely normal chest X-ray. And then when he came back, so you can see that there are some left lower lobe changes. You can see that there's this interstitial pattern, but if you look behind the heart, there are some air bronchograms there already. So this was when he was admitted to the ward. And then this was, as you see, this is post-intubation. So the endotracheal tube is in situ and the central line there as well. Left lower lobe collapse. And then even more severe, like more diffuse changes, interstitial and some alveolar pattern as well there. So this is post-intubation. Post-discharge, he had a CT chest. So I just put up some images on that so that we can relate to the ultrasound changes as well. So you see that these are the changes that we see on the ultrasound as well. So ground glass opacity, alternating with normal lungs, and then a little bit of consolidation there. Again, after that, it's a piece of normal lung. So this is what you see on the ultrasound as well, like 1 centimeter to the other. You can see quite abnormal changes, and then a normal piece of lung after that. So as you see, again, mostly it's a ground glass opacity that you see, and then this is what they call that Casey paving pattern. So the ground glass opacity with septal thickening all the way down, R1, you see that there is some pleural irregularities with some B lines there. This one is only 1 B line. And then if we move into another area, this one is roughly normal. You could argue that the pleural line here is slightly thickened. Still in R1, but again just a few centimeters away from that. See how quite a few B lines appear here. So like 1, 2, 3, 4, at least four B lines come in and out of view. So this is quite abnormal. And then R2, see how that pleural line here is much more thickened. It looks more irregular. Zoomed in. So this is what we call that subpleural consolidation. So that little black bleb right underneath the pleura. So that's your subpleural consolidation with a B line coming off it. And then R3 up in the armpit. Very abnormal, lots of B lines, pleural thickening. So this is the confluent B line that we can see. Same here, lots of B lines, white, shiny lung. And then R4 down on the diaphragm, liver, and then confluent B lines coming through as the patient breathes, or as we breathe for them on the ventilator. Left upper, again 1 B line, bit of thickened pleura. Thickened pleura B lines. And L3, this is the shiny part where it's confluent B lines. It's almost like the whole rib space is taken up by. So when it's looking like this, we say that it's 10 B lines, so 1 B line per 10% of that rib space. So then if the whole rib space is taken up by confluent B lines, this would be 10 B lines. Same here. So very, very significant changes, very abnormal. L4 down on the spleen. So you see the spleen there, and the diaphragm. So the lung doesn't come, and the lung comes in over there. So you see how it's there. This one is not as clear, and I think the stomach came into the view, so it's sort of obscure. So this dirty shadow in the middle would be the stomach. So in the end, he did well. He was extubated on day 4 of his intubation, and then went out to the ward, and he recovered fully. And then the third one is a 79-year-old male with lots of comorbidities. So you see he had bronchiectasis, he's cachectic, he's only 42 kilos, with severe OSA and some pulmonary hypertension, coronary artery disease. So he had lots of comorbidities, plus he had COVID as well. So they were measuring their SATs at home, and they found that his SATs were down into the 70s. So they brought him in. He presents to the ED, and his presenting complaint was shortness of breath and the low SATs. But then when they put him on some face mask oxygen, then turned out that he was a CO2 retainer with all those pre-existing problems. So his CO2 went up to about 100. He became obtunded, and they asked us to take him to ICU, which we did. We changed his oxygenation targets. So we were aiming for about SATs of 85 or so. So we took the oxygen off, and then thankfully he woke up slowly once his CO2 came down. So then he came to us. We did an ARP form with all those comorbidities, so he wasn't a candidate for intubation. Later on, he had a CT, so I'll show you his CT first. So there's lots of chronic changes, as you see. So signs of bronchiectasis and some cystic changes there. But you see there's some ground glass opacity in certain areas there, and there's some basal consolidation pattern there as well. You see. That was his chest X-ray from earlier on. So there were chronic changes, definitely there were chronic changes. And to be honest, I think his COVID was just a mild disease, but it was enough for him. He was on a knife's edge anyway with all his comorbidities, and that was enough to tip him over. And I think his COVID wasn't particularly severe. So you see there's this chronic pleural effusion. There was some pleural effusion on the left as well as on the right, bronchiectatic changes. So that's right one. You see that the pleural sliding is extremely subtle. So he wasn't really taking big breaths, and he was a very, very difficult patient to scan on because he was so cachectic that his ribs were all very prominent, and you can't really see, you know, you need a liter of jelly to get in between the rib spaces. So it's really hard to image these patients. There is a subtle pleural sliding there though. And when I asked him to take a deep breath, he always did. And you see there's a B line, and it sort of slides and moves, but very, just a little bit. So this one is very hard to assess, but certainly there is a B line there with some pleural thickening. Same there. R2 again. So this is not the best image. Not a great deal of pleural sliding. Hopefully there's a bit more there. Subpleural little consolidation with one B line coming off it. This is when I asked him to take a deeper breath. So B lines, maybe a couple of B lines, 1 and 2. So they come in and out of view. And then right 4 down on the liver. So you see that there is a larger area of consolidation there. So this is what we call, that white line that you see there is the shred sign. So that's sort of the boundary around a larger area of consolidation with some B lines coming off it. See how, so all this wedge-shaped abnormality, so this is an area of consolidation. So that's a big consolidation, and that white line around it is the shred sign. These are the B lines that you know from previous images. And then I just took a few images. So if you imagine that I had a look from more from the anterior and then started to go more posterior and then looking up and down and around and trying to see how big this area of consolidation is. And it was quite significant. But I think it was again part of his chronic pattern, not new from COVID. L1, again, very subtle, but there is some pleural sliding there. This is normal. L2, maybe one B line. If you really want to see a B line, there might be one there. And then L3 up in the armpit. This is largely normal. See how close his pleura to the skin is. So it's like 0.5 centimeter, and that's his pleura already. And that's L4. Spleen, a pleural effusion. See how, so that big black area, that's a quite large pleural effusion on the left, and that's the lung coming in with a couple of B lines over there. Same here, B lines coming through pleural effusion and some collapsed lung more posteriorly, so that's a bit of a collapse, like a compression atelectasis from the fluid. And this big white thing towards the back, I wasn't exactly sure what it was. I think it is probably another larger area of consolidation there, again related to his chronic changes and his bronchiectatic changes. And the same, you can see there. So the pleural effusion on this side was slightly bigger. So that's the end. So 3 cases, 1 mild, 1 moderate, 1 severe. They all did well. They all left ICU. And we could see all the frequent changes that have been reported in various papers. So this was a good summary of all those changes that you can see. Thank you.